Good morning, everyone. Welcome to Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. I'm Ashrith Guha. I'm a heart failure transplant cardiologist, and in the studio with me is Dr. Sharif Naga, who is the director of our Echo Lab. And we are really pleased to welcome Dr. Sanjiv Shah from Northwestern, who is going to be talking about new approaches to HFPEF in the era of precision medicine. Dr. Shah is Stone Endowed Professor of Medicine and Director of Research at Bluhm Cardiovascular Institute and Director of the Center for Deep Phenotyping and Precision Therapeutics at Northwestern University. Dr. Shah started the first HFPEF clinic, dedicated clinic in 2007 in the world, and since then has been pioneer in this field, leading multiple NIH studies and 25 international clinical trials. He also has been instrumental in defining HFPEF better and phenotyping HFPEF better and advancing our understanding. So we are really looking forward to Dr. Shah's presentation today. Welcome, Dr. Shah.
Well, thank you for that very kind introduction, and it's really a pleasure to be here with you all today. So I'll go ahead and get started talking about new approaches to HFPEF in the era of precision medicine. Here are my disclosures. So I often like to start with this slide, and this is a paper, not the first description of HFPEF, but one of the earliest from Eric Topol when he was a fellow at Johns Hopkins, called Hypertensive Hypertrophic Cardiomyopathy of the Elderly. And this is typically what we thought of HFPEF early on, diastolic heart failure before the early 2000s. It was a thick left ventricle, a small LV cavity, an upward and leftward shifted end diastolic pressure volume relationship. And we were kind of stuck here. Multiple phase 3 trials were done, charm preserved and eye preserved with ARBs, PEP-CHF with an ACE inhibitor, and TopCat with spironolactone. And they were all disappointing. There's a silver lining on each of these trials, but the top line results didn't really meet our expectations. Now, we eagerly await further neprilysin inhibition trials beyond Paragon, of course, SGLT2 inhibitors, novel MRAs, and intraarterial shunt devices and others. But we were clearly stuck when we were thinking about diastolic heart failure in this way. And so this is why I started the dedicated HFPEF program at Northwestern. And for those of you who may be interested in developing your own program in HFPEF or other specialized programs, you can look at this paper written by myself and 3 of my mentees who started programs of their own, which are flourishing at their universities. But what we found when we were seeing these patients day in and day out is that HFPEF is really a heterogeneous syndrome. Any of you who take care of these patients knows this quite well. It's sort of a wastebasket diagnosis. We've excluded all other things. They have elevated filling pressures, a preserved EF, and this is what we get. And in 2021, we now know that HFPEF is much more than just diastolic heart failure. It not only involves the heart, but the lung, the liver, the visceral adipose tissue, the kidney, the skeletal muscle. It's still hypertensive remodeling and ventricular and vascular stiffening. But also, and importantly, sedentary lifestyle and poor fitness are major risk factors for HFPEF as opposed to HFrEF. And of course, there's the burgeoning epidemic of obesity and metabolic stress. All of these are coupled with aging that leads to a global loss of cardiac, vascular, and peripheral reserve, culminating in the HFPEF syndrome. Now, the current prevailing heart failure hypothesis is that HFrEF on the right results from primary myocardial injury, either ischemia, infection, toxins. And there's this primary myocardial injury, which then sets off a neurohormonal cascade, leading to ventricular dilation and dysfunction. We think that HFPEF is comorbidities resulting in a peripheral insult. Something in the blood is circulating and causing a secondary myocardial injury and culminating in the HFPEF syndrome. And I think that's really important. There's certainly some overlap here between HFPEF and HFrEF. And of course, there's heart failure with mildly reduced EF. But at the extremes, these are very different syndromes. So let's go on to HFPEF diagnosis. Well, I think it's really important to remember that we have a diagnostic toolbox, the physical exam, biomarkers, echocardiography, which I feel is the cornerstone, but also invasive hemodynamics, especially invasive exercise hemodynamics, coronary evaluation in all patients, cardiac MRI, and the cardiopulmonary exercise test. And so what is HFPEF? Well, it's signs and symptoms of heart failure, a preserved or relatively preserved EF, objective evidence of elevated LV filling pressures at rest or during exercise. And that's really important. Many patients are, quote, normal at rest, but only really have symptoms and abnormalities with exercise. So what do we use? Well, we can use an elevated BNP or LA enlargement or dysfunction, elevated pulmonary capillary wedge pressure at rest or with exercise. And we want to really see that there's a cardiac predominant problem and exclude other causes that result in heart failure with a preserved EF, but are not typical HFpEF and have specific treatments. I think a major advance have been HFpEF scores, both the H2FPEF score that I'm showing here and the European Society of Cardiology HFA-PEF score. But I like this one because it's so simple, developed by Barry Borlaug and colleagues at Mayo Clinic. But remember, this score is really for when there's equivocal diagnosis. So you have a patient with dyspnea on exertion, and you're trying to figure out, is it HFpEF or non-cardiac dyspnea? And there's heavy hypertensive, AFib, pulmonary hypertension, elder, and elevated filling pressures. And note the EDE prime greater than 9, that's the cutoff they found to be best in terms of test characteristics. And this is really easy to apply in the clinic. It can be automated into EPIC and the electronic health record. And a score of 5 or higher states that the patient has a greater than 80% chance of having HFpEF. So I think this is really important, and we need to educate our colleagues, general cardiologists, and primary care physicians on the use of this. But sometimes there's a doubt. And so when in doubt, perform a right heart catheterization and perturb the system. Exercise, passive leg raise, and volume challenge are all things that we can do. And this is a seminal study also by Barry Borlaug, where he shows that in non-cardiac dyspnea in purple, there's a slight rise in the pulmonary capillary wedge pressure, but a marked rise in blue in patients with HFpEF. So even with the feet up, the wedge pressure goes up dramatically. And just with 1 minute of exercise here, we're reaching pulmonary capillary wedge pressure of almost 30. So this is really, I think, a useful tool when the diagnosis is equivocal. Now, always try to determine the etiology of HFpEF or the heart failure syndrome in a patient with preserved EF. This is critical, and I think something that we don't always do. We don't often do this. We say, though, they have diastolic heart failure, there's not much we can do about it, and we wash our hands of it. But this is really, really detrimental to our patients. So I'm not going to go through each of these, but this is a differential diagnosis of HFpEF. There's many things, like I said, that can cause the heart failure syndrome with a preserved EF. But it's not typical HFpEF, cardiac amyloid, hypertrophic cardiomyopathy, cardiac sarcoid, constriction, valvular, et cetera. We really need to go through these. And so I always tell my fellows when they're rotating with me in the HFpEF clinic, know your zebras. HFpEF is a diagnostic mystery until proven otherwise. Of course, a careful history and physical, and review the echo images yourself. Some clues to zebras that I've found to be helpful is HFpEF in the younger patient or a low H2FPEF score. So say you have a patient with overt heart failure, fluid overload, heart failure hospitalization, elevated BNP, but the H2FPEF score is low. That should really tell us something else is going on. Kussmaul's sign, elevated jugular venous pressure with inspiration. A diastolic septal bouncer, variation in mitral inflow could suggest constriction, and speckle tracking strain bullseye map patterns have been really helpful in our understanding of etiologies of HFpEF. So I'll just give you some examples here of patients with HFpEF and LVH in my clinic. And you can see the different types of patterns. So TTR amyloid or AL amyloid will have that cherry on the top sign with apical preservation. You'll have patients with idiopathic restrictive cardiomyopathy on the upper right who have kind of a heterogeneous pattern. Lower left, C, apical HCM with loss at the apex. And D, this is a patient with end-stage renal disease. And possibly some reports are saying that in the lateral wall there, a decrement in strain is indicative of Fabry disease. So let's go on to the current evidence for treatment of HFpEF. These are the ACC-AHA guidelines on HFpEF, and they're pretty sparse, but I do think it's helpful to treat to a systolic blood pressure goal of less than 130, decongest, and I always try to use an MRA if the GFR is greater than 30, or the potassium is less than 5. I treat coronary disease pretty aggressively. I treat AF aggressively, but I always think a heart rate in the 80s is ideal because these patients do have low stroke volumes. They can't augment their stroke volume. They have left atrial failure, and they're not going to tolerate a low heart rate very well. And remember that PDE5 inhibitors and nitrates, as much as we want to use them, our trials thus far have shown that they don't work. So this is my treatment algorithm. First, I ask, is the patient volume overloaded? So I've made the diagnosis, are they volume up? Yes, then I will use diuretics. I use MRAs, and I try to use SGLT2 inhibitors. We'll go over the evidence there in a second. So these are really important adjunctive to loop diuretics, and then I try to minimize the loop diuretic thereafter. Now, once I've treated their volume overload, or they don't have volume overload to begin with, I treat their comorbidities quite aggressively. And then, of course, heart failure education, I think, is very important, exercise training. And then if they have an EF that's less than 55 to 60 and a congestive phenotype, and this is really where a lot of the Paragon data is coming in to tell us that if they have the lower EF and a congested phenotype, then sacubitril valsartan. So if they're on MRAs already, they've been hospitalized recently, that's probably the type of patient that's going to benefit. Now, some patients, many patients, will have persistent symptoms and or heart failure hospitalizations. And that's where we really need to refer to the heart failure program, ideally a HFPEF program, evaluate for zebras. Once again, are there atypical etiologies or are there worsening comorbidities? We use a lot of implantable hemodynamic guided management. I think that's been revolutionary for the field. And then, of course, we try to enroll in HFPEF clinical trials. So let's go through these a little bit. So first, we want to decrease congestion and reduce heart failure hospitalizations. You're all well aware of the TOPCAT and CHAMPION trials. And in TOPCAT, even overall, even including Russia and the Republic of Georgia, there was a reduction in heart failure hospitalization. And we saw that to a greater extent in the Americas. So I really do think it works. And of course, there was a marked benefit in the CHAMPION trial with the CardioMEMS. But there's a lot of ongoing trials that I think you should know about. First of all, Paraglide is hospitalized HFpEF, and that's where we're looking at sacubitril valsartan. There's Transform, so torsemide versus usual care for hospitalized heart failure of all EFs. MRA, there are two more spironolactone trials, both called SPIRIT, and a trial I'm very excited about called Fine Arts, finerenone, which is a novel non-steroidal MRA. And in the Fidelio trial in CKD, it showed quite a bit of benefits. So we're very hopeful for that in HFpEF. And then, of course, very excited about the two SGLT2 inhibitor trials, Emperor, Preserve, and Deliver, which hopefully we'll report out later this year and next year. And this SGLT2 inhibitor, I do think is real. Of course, we're waiting for the data, but here's the SOLOIST worsening heart failure trial. So worsening heart failure, diabetics, big benefit with sotagliflozin, an SGLT1 and 2 inhibitor. And in the subgroup analysis, it looked, if anything, it helped the HFpEF patients more than even HFrEF. So that's very intriguing. But these days, we can use at least dapagliflozin in almost all of our patients because of the DAPA-CKD trial and the change in the FDA labeling. Now, any patient with HFpEF with worsening chronic kidney disease, even if they don't have diabetes, can get approved, at least FDA approved, for one of the SGLT2 inhibitors. And look at this improvement in reduction in cardiovascular death, renal death, decline in GFR, decline in heart failure hospitalization and cardiovascular death, really quite amazing results. And so I think even while we're waiting the results of these big SGLT2 inhibitor trials, we should be using these drugs in our patients with HFpEF. And as you can see here in the subgroup analysis, really no difference at all between diabetics and non-diabetics in the DAPA-CKD trial. Now there's diet and exercise training. This is the SECRET trial, Delane Kitzman at Wake Forest. Both caloric restriction and aerobic exercise training were helpful and in some cases additive. And this is a single center study. But recently, earlier this year, the OptimX CLIN trial was published. And this looked at high intensity interval training versus moderate continuous training versus guideline control in HFpEF. And this was a multi-center trial in Europe. And if you read the article, they said it was neutral. But actually, it just didn't meet their really kind of enthusiastic and unrealistic endpoint. It actually did improve. It was, now, of course, high-intensity interval training and moderate continuous training were similar, but they were both a lot better than guideline control, but only when in person. And this kind of attenuated during telehealth. And so this tells us that we really need to do cardiac rehab in-person exercise training is what seems to work in HFpEF. And I'll just note on the upper right here, you'll see that the SECRET trial and the OptimX CLIN trial were quite different in terms of the peak VO2. I don't know about all of you there, but my patients are more like these, peak VO2 in the 14s. But even if you have a healthier cohort of HFpEF patients, they do seem to benefit from exercise training. Now, step 3, which is the final, is the phenotype guided approach. And I've been talking about this for 15 years. And now it's, sort of, it seems, that this always has been the case that we need to decipher this heterogeneous syndrome, but it wasn't always the case. And I think that a lot of us that see these patients in and out, day in and day out, we've been arguing to do better phenotyping of these patients to resolve the heterogeneity. So this is an editorial I wrote in 2013 in JACC, Matchmaking for Optimization of Clinical Trials of HFpEF. And what I show that there's many ways to slice the HFpEF pie, But this is just one way where we have patients with elevated filling pressure just with exercise, some with overt volume overload, and those that have pulmonary hypertension and RV failure. And although all of these patients have HFpEF, we probably should treat them very differently. And again, there's many ways to subphenotype HFpEF, and that's what I'm going to spend the rest of the talk talking about. How do we resolve this heterogeneity? Well, one way is to look at the extent of myocardial involvement. So all patients have elevated filling pressures and a preserved EF. But whether this is extracardiac or cardiac is on a spectrum, and most patients are somewhere in the middle. There's both. And so we've been using abnormal strain to kind of figure out who of HFpEF has a really sick myocardium. And the question is, does the therapeutic responsiveness of cardiac-specific medications increase if there's a more myocardial involvement? And we've seen this now in Paragon, we've seen it in TopCat, just using EF, a crude measurement, but the lower the EF within the normal spectrum of EF, the more cardiac involvement, the more they're going to benefit from neurohormonal therapy. And so we can phenotype HFpEF beyond EF. If there's HFpEF with reduced longitudinal strain, that tells us something. There's contractile dysfunction, myocardial fibrosis, infiltration, microvascular dysfunction, maladaptive hypertrophy. But if it's preserved, then we're thinking, is there primary LA dysfunction, ventricular arterial coupling, extracardiac, RV? Is there something else going on? So very, very helpful. And maybe there's not speckle tracking strain available. Well, then we would use tissue Doppler. We often look at the E prime, but we don't pay attention to the S prime or the A prime. So we should start looking at those. And low S prime and A prime are also signs of very sick myocardium. Shortened ejection time, prolonged isovolemic times, even the ECG. We published a study showing that the increased QRST angle is associated with a more myocardial sicker heart within HFpEF and worse outcomes. So let me show you a few examples. This is a 62-year-old man who had alcoholic liver disease, very dyspneic, confused, fluid overloaded, comes to the echo lab. Now, I'm not sure it's playing very well over the video, but his EF was preserved. And I even measured it myself. The EF was 57%, but the myocardium just looked funny. And so we did speckle tracking, and his global longitudinal strain was very abnormal at 12.3%, despite the preserved EF. And remember that for the global longitudinal strain, absolute values, normal is greater than 18, borderline 16 to 18, and abnormal less than 16. So this was very abnormal. So he came to my clinic. Like I said, he was confused, very volume overloaded. I increased his diuretics. I started carvedilol and up-titrated. And look at this result. Blockbuster result 6 months later with his global longitudinal strain normalizing and improving. And his confusion went away. He was no longer short of breath. And so this may be a masked alcoholic cardiomyopathy due to the liver's disease and low SVR. He had a preserved EF, but this is the kind of patient after a liver transplant where the LV falls apart. And so again, looking at the myocardium is important. Here's another patient, a 62-year-old man with HFpEF and AFib. Previously healthy, no other risk factors, just this new onset AF, but now with overt HFpEF, elevated BNP. These are still images from his TEE during his cardioversion. He had a thickened, sparkling texture to his myocardium. And so he came to clinic. They was referred to me. They were thinking cardiac amyloid. And he did have pretty severe diastolic dysfunction, as you see on the left. But his speckle tracking strain map did not look like cardiac amyloid. There was a decrement in the septum and anteroseptum, part of the anterior wall. And so we got a cardiac MRI, and there was patchy late gadolinium enhancement, especially in the septum, which matched up with the speckle tracking. And so we ordered genetic testing, and sure enough, he had a TNNT2 pathogenic mutation and a known cause of HCM with a restrictive cardiomyopathy pattern. And so again, we need to look at the myocardium, and that helps us phenotype HFpEF. So how do we treat myocardial HFpEF? Well, I talked about neprilysin inhibition, spironolactone. We can target the natriuretic peptide PDE9 system. Antifibrotic therapy. Very soon at ACC, the Pirouette trial will report out. That's pirfenidone, an antifibrotic for HFpEF. Myosin modulation, both inhibition and activation. And then inotropes. This is a fascinating, just a single center acute trial of milrinone. So why would milrinone help patients with HFpEF? So this is acute exercise. Look at this drop in wedge pressure acutely with milrinone. And wouldn't it be fascinating if milrinone, an inotrope, and other inotropes were helpful for HFpEF where they haven't really panned out for HFrEF? And so why would an inotrope help HFpEF? Well, if we improve LV longitudinal contractility, we're basically improving the LA reservoir function. As there's more descent of the base towards the apex, through the mitral annular motion, we're stretching out the LA when it's filling, and we can lower that pulmonary venous pressure. So that may be one mechanism, maybe splanchnic. We still await those findings. But what about machine learning? So we have a heterogeneous clinical syndrome, HFPEF, and we can use unsupervised machine learning or pattern recognition to identify discrete phenogroups. And then that can help us clinicians derive new clinical and biological insights. And that's exactly what we've been doing. Now, with a lack of tissue, we've been using echocardiography primarily for deep phenotyping, but you can do this with proteomics in the blood, metabolomics. We've been doing a lot of that more recently. But in our early studies, we were simply using echo. And so this is our study on phenomapping of HFPEF, now published several years ago, where we took a variety of quantitative phenotypes, mostly echocardiogram, but ECG, laboratory data, clinical physical exam factors, and that's all that's there. Each row is a quantitative phenotype. There's no genetic data, there's no proteomics or anything like that. These are all just phenotypes in each row, and each column is one of 400 patients of mine with HFPEF. And you can see red is increased, blue is decreased. There's quite a bit of heterogeneity here. And so this is, if anything else, this is, or nothing else, this is proof that this is a really heterogeneous syndrome. And then we use something called model-based clustering, which is a Bayesian technique to identify that 3 is the most optimal, most parsimonious groups of patients. On principal component analysis, they really splay out quite well. So 3 very different groups, and they have very different outcomes. So these are really different trajectories of patients. And if we apply it to, adding the prognostic value over magic risk score and BNP, this is meaningful is all we were trying to say. And importantly, and you should look for this in every machine learning study, it needs to be replicated in a different cohort of patients. And so we replicated this prospectively in another 107 HFPEF patients. And when we apply it to TopCat, what we see is we replicate it, so different survival on the top right, and then it was actually the lowest risk phenogroup 1, that benefited the most from spironolactone. So again, this is a way to use unsupervised machine learning to target patients and see that they may benefit differentially from therapies. When we think about HFrEF, that's also heterogeneous, but HFrEF is therapeutically much more homogeneous. And HFPEF is not only etiologically and pathophysiologically heterogeneous, but it's therapeutically heterogeneous, and we need to find these subtypes. So let's look deeper into some of these subtypes. There's phenogroup 1, 2, and 3. Pulmonary capillary wedge pressure is elevated in all the groups, and they all had a preserved EF and LA enlargement, but as you can see from their echoes, very different phenotypes. So group 1 had the least cardiac remodeling and dysfunction and the lowest BNP. Group 2 had the most severely impaired myocardial relaxation and the highest prevalence of diabetes. And group 3 had the most severe cardiac electrical remodeling, renal dysfunction. You can see the RV is pretty sick. And so we call group 1 the BNP deficiency syndrome, group 2 the extreme cardiometabolic syndrome, and group 3 the RV failure cardioabdominal renal syndrome. So let's look into this. And I think what I'm trying to show here is that so you do the machine learning analysis and you pat yourself on the back, but really that's just the starting point. It's the tip of the iceberg. We need to dive deeper. What do these groups mean? And that's what I want to show you today. So let's talk about the BNP deficiency syndrome. We are now all well aware that many patients with HFPEF, up to a third or more, have a normal BNP, especially in the outpatient setting. So their BNP is below thresholds we typically use to diagnose HFPEF. So we really always need to remember a BNP should not be used to rule out HFPEF. Patients can clearly have the HFPEF syndrome, and many may have this chronic BNP deficiency, just like any other hormonal deficiency. There's many causes on the left of a low BNP that we now know, not just obesity, but genetic, lack of wall stress, insulin resistance, increased androgenicity in women, even African ancestry. And what does a chronic BNP deficiency lead to? Hypertension, fluid retention, even increased adiposity due to the low BNP. And that accumulates in the pericardium, the epicardium, excessive chest wall fat, and causes pericardial constraint and HFPEF with minimal intrinsic myocardial involvement. The heart's often pretty healthy, but what's going on is you have volume expansion from the obesity, and then you've got this pericardial constraint due to all the adipose tissue. So let me show you an example of a 74-year-old woman with a BMI of 46. BNP is only 28, and she has severe pericardial and epicardial fat over the RV. I don't know if it's displaying very well, but there's a prominent diastolic septal bounce indicative of ventricular interdependence. And sure enough, on invasive hemodynamics, had tracings that looked just like constriction. Peak inspiration showed RV and LV discordance, as you can see here. And however, on MRI, it was really just severe pericardial and epicardial fat. The pericardium itself was normal. So this is the classic obese BNP deficiency phenotype of volume expansion and pericardial constraint due to all this obesity. And so how can we treat this phenotype? Well, I'll just show you two examples. This is a very similar patient to the one I just showed, where I prescribed a GLP-1 receptor agonist. And between June of 2017 and December of 2018, her BMI went from 39 to 31. I mean, amazing benefit. And she's now off of all diuretics, all antihypertensives, and now has class 1 symptoms. This is a ketogenic diet using a breathalyzer to confirm ketosis. So I got one of my other patients into this program. In a 3 months time point, she was able to reliably follow the diet, establish ketosis through the breathalyzer, as you can see here, and weight went down 20 pounds, and she's now went from class 3 to class 2 symptoms. So definitely something there, and I think this will be a major area of investigation in the future in HFPEF. So there's pharmacological and dietary weight loss, targeting the visceral adipose tissue-induced splanchnic vasoconstriction, so greater splanchnic nerve ablation. There are adipokines that vasoconstrict that can be targeted, augmenting BNP or its downstream effects. If you don't have BNP, let's give you more. So there's things that we can do to treat that as well. What about phenogroup 2? The extreme cardiometabolic syndrome is what I call it. And this is really the classic, what we now call the Paulus paradigm, after Walter Paulus and Karsten Schoppe from Europe. They described this in JACC several years ago. Here's a summary of it in a paper we published in 2016. So what's going on in this paradigm is you have comorbidities that cause systemic inflammation. And this is the thing that's going on in the blood that then poisons the endothelium in multiple organs, not just the heart, but the lungs, the skeletal muscle, and the kidney. And in the heart causes deranged endothelium cardiomyocyte signaling such that there's interstitial fibrosis, hypertrophy, and also cardiomyocyte stiffness. And so the question is, what can we learn about this? Is it real? And what can we do about it? And so we've been studying this for several years. This is adenosine transthoracic Doppler of the coronary flow reserve of the mid to distal LAD. And you can do, with TTE, you can actually do coronary flow reserve. And we've been doing it for several years now at Northwestern. And we used this in a study called PROMISE. This was a 5-center study around the world. And what we did was we looked at this to measure CFR in patients with HFPEF. On the left is a patient with HFPEF with normal coronary flow reserve, no coronary microvascular dysfunction. And on the right is a patient with very severely impaired CFR of 1.6. And when we look at this in aggregate in this prospective multi-center study, the prevalence of coronary microvascular dysfunction, or at least a reduced CFR, was 75%. And the worse the CFR, the more albuminuria as a marker of systemic endothelial dysfunction, the higher BNP, the sicker the RV, and even the endopat, reactive hyperemia index, that's a marker of systemic endothelial dysfunction, was also more abnormal. So this really does seem to be something there with this. And so we went further in PROMISE and we decided to do a proteomic analysis. And what we did here is we used a deductive approach where we said, okay, 47 of these 248 proteins are known to be associated with inflammation. And we used principal components analysis to basically reduce the dimensionality of all these proteins. And so we have these principal components. On the right side is this inductive approach saying, we don't know if these proteins are somewhat involved in inflammation or not. So we did a unsupervised machine learning approach called weighted co-expression network analysis. And we found 4 protein clusters. And then we basically found that 3 of them are involved in inflammation. And then we looked to see, are these principal components or these clusters, these groups of proteins, are they mediating the association between comorbidity burden and abnormal cardiac structure and function in heart failure with preserved EF? And so the first thing we found, which was really fascinating, is that there is a signature of inflammation in HFPEF. We validated this at Northwestern as well. And it's this in this turquoise modular cluster here. You can see it's centered on TNF-alpha receptor 1, which is basically like the remnant, the signal that TNF-alpha has been around. TNF-alpha goes up and comes down pretty quickly, but it leaves a signature that it's been there. This TNFR1 is circulating. And like I said, this was really quite present in HFPEF patients at Northwestern, and it's not present in patients with comorbidities without heart failure. And so this really seems to be an important marker of HFPEF. And if we look at this inflammation cluster, it does mediate things like the association between comorbidity burden and E-velocity, a marker of elevated filling pressures. And when we look at network ranking of these markers, what we find is, again, TNFR1 is a central hub. And what may be going on the right, if you see here, is the comorbidities cause this release of TNF-alpha, TNFR1 goes up. In basic science studies, that's been shown to cause an abnormal T regulatory cell response, which promotes interstitial fibrosis, which could increase LV stiffness and elevate filling pressures. So what are we doing here? Well, we're doing more metabolomic profiling and combining a multi-omics approach with proteomics. We have two trials, MPO inhibition and the Amethyst trial with a URAT1 inhibitor, Verenurad. We're studying the role of macrophages in HFPEF pathogenesis. And finally, phenogroup number 3, the RV cardiorenal syndrome. You're all well aware that RV failure causes a tremendous stress on the venous system, the central venous system. And those increased venous pressures, they do a lot. They cause cardiorenal syndrome. But one thing that's not been looked at too much is that they cause the splanchnic congestion. And that's something that we've been studying. So if we think about splanchnic congestion, that results in a hypoxic environment in the enterocytes. And if there's a hypoxic environment because blood flow is not good because of this high venous pressure, acidosis is going to ensue. And on the brush border, there's this NHE3, sodium hydrogen antiporter, which plays a major role in sodium and fluid resorption in the gut. And so if you're more acidemic in the enterocyte, you're going to try to extrude hydrogen ions into the gut lumen. And this is going to get activated, at least this is what we hypothesized, in HFPEF with right heart failure. And so if you have a low pH, that's bad because you get microbial dysbiosis in the gut, increased gut permeability, increased inflammation, increased susceptibility to infection, sepsis, and cachexia. This is exactly what we see in right heart failure. And at the same time, we have increased fluid retention because of all the sodium resorption, and that's not good, causing worsening venous congestion, renal failure, worsening heart failure, and death. And so we did a small pilot study at Northwestern called Victory, the visceral congestion in heart failure study. We took hospitalized heart failure patients and non-heart failure hospitalized controls. Some of my students gathered their stool, and we can actually extract exfoliated colonocytes. Millions of colonocytes are exfoliated with each bowel movement, and we can extract these from stool. And then we can do flow cytometry. So this proved the hypothesis that in heart failure, at least hospitalized heart failure, NHE3, both on the cell surface and intracellular, are majorly upregulated compared to controls hospitalized for non-heart failure reasons. And we also show here in some preliminary data that it does correlate with increased RV size and worse RV function. So we do think something is there, and we're following up with larger studies. So how are we furtherly investigating this group? Well, we have two trials, pulmonary vasodilator therapy, Serenade and Southpaw. Both were stopped early due to slow enrollment, but both should still report out. So we'll get some data on that. We can improve RV function or improve the unstressed blood volume. What that means is the ability of the gut to hold onto that blood and not push it up to the heart. And last year at HFSA, we showed in the HELP trial that levosimendan, which does both of these things possibly, resulted in a 30-meter improvement in 6-minute walk test compared to placebo, and nothing improves 6-minute walk test in HFPEF. So pretty exciting. And this is going to be followed up with a phase 3 trial. And also unilateral greater splanchnic nerve ablation. We want to improve the splanchnic venous capacitance, the ability of that venous system to relax and be a buffer. And I reported the first in human data at HFSA last year, and we have a sham-controlled trial called Rebalance going on right now. So let's review this because I think it's important, the fast versus slow mechanisms of congestion. Of course, we all know the slow mechanism of congestion, renal and dietary indiscretion, sodium and water retention. But remember that any minor precipitant can cause sympathetic activation. And in some patients, this is constitutively activated. And this causes mobilization of the splanchnic venous reservoir and then increase in congestion due to the stiff heart. And when it's always activated or venous pressure is very high, that reduces venous compliance, and you get this kind of all the time and can cause the cardiorenal syndrome. And so this is where GSN ablation and levosimendan may be really quite helpful, especially in these patients with right heart failure, this phenogroup number 3. But how do we apply phenomapping to the real world? Well, this is what we did in our study. We took a history, physical, labs, ECG, echo, but the thing that, and then we did the phenomapping. Now, the difficult part about this was that each echo was quantitated for about 70 quantitative phenotypes. It was done in a core lab in my lab, and it was very painstakingly and took a long time. We can't expect that to be something that we can do, at a large scale. And so this is where we use deep learning of the echocardiograms to do this for us. And so this is a study published by Rahul Deo's group in collaboration with ours, machine learning of echo, where we take deep learning to identify the views, automated identification of the cardiac chambers, active appearance models for segmentation, and then we use particle tracking for tissue displacement, velocities, and strength. So this combines deep learning with computer vision, and this can be done throughout the whole echo server overnight and really go through a lot of echoes to quantitate and also make diagnoses. And so the question is, can deep learning work? And now many groups around the world have shown this, that you can use it to identify different views. This is from the study that we published in CIRC a few years ago. But even views that are cut off or not right, you can really differentiate with deep learning. And, besides identifying phenotypes of HFPEF, we can use it to identify diseases like cardiac amyloid. I'm sure you can see these and it's obvious even to non-echocardiographers that something's different here. And yet cardiac amyloid gets missed every day. And I've, thought for 10 plus years that a computer could easily pick this out if it's trained to do so. And so we've been doing this automated measurements with disease detection. This is from that paper, LA volumes, global longitudinal strain. We can diagnose cardiac amyloid, and this gives us hope that we can diagnose other phenotypes of HFPEF. And so this is what you see with the amyloid detection model. And just this week, our papers on this came out in Nature Communications. Deep learning alone with no computer vision has an area under the curve of about 0.91 all the way up to 1 in some cases, where it's really performing well. And this paper goes into using both ECG and echo to do this, a really kind of cutting edge, and I think can be utilized in our clinics and to automate the diagnosis of amyloid. We're working on HCM and pulmonary hypertension and others. We can track people over time using machine learning. This is in the example of cardio-oncology, but it can be done in heart failure patients as well. And we recently published also in Nature Communications this week using just medical claims data. Here we use machine learning of medical claims data in thousands of patients to identify a model that can tell us that a patient with heart failure might have cardiac amyloid. And we validated it in multiple groups. We're currently prospectively validating. It can give us clues to things that are antecedent to cardiac amyloid. And the reason I'm showing this today in the HFPEF talk is this is the kind of thing that we're trying to do with HFPEF. We find a specific subtype of HFPEF, then we can use machine learning to auto-identify it, and that will be very helpful for the future. So how do we do matchmaking for targeted therapeutics in HFPEF? Well, we have a heterogeneous syndrome. We want to do subphenotyping. That can be quantitative imaging, cardiac biopsy, liquid biopsy, exercise phenotyping, machine learning, and ultimately we want phenotype-specific treatment. And so one way we've been doing this at Northwestern is taking a page out of oncology by doing umbrella designs. So we have a huge HFPEF program. We do deep echo phenotyping with exercise, and we also do invasive exercise hemodynamics, and we put them into one of these bins. And of course, this changes over time as we learn more. But once we get the bin, then we assign them to a trial. And this has worked extremely well for us, and I think can work very well for centers like yours as well. So let me show you one example. There are patients with HFPEF who have very high LA pressure with normal or near normal RA pressure. They don't have very much RV failure, and their PVR is normal or relatively normal. This is the LA myopathy, the LA failure phenotype. And we showed several years ago that worse LA reservoir strain is associated with higher pulmonary vascular resistance, worse outcomes, better than LV or RV strain. And really, there are many ways to get to abnormal LA mechanics in HFPEF, but when you get there, and you have chronic LA pressure and volume overload, reduced atrial emptying, what happens is you have low exercise tolerance and adverse outcomes. So it reasons that we should be targeting the left atrium in HFPEF. And I like to say that heart failure with reduced EF is failure of the LV, but HFPEF is failure of the LA. And I say that tongue in cheek, but just remember that with a healthy LA, just like with a healthy kidney, you don't really develop the syndrome. It's when the LA fails that really we start seeing the symptoms. And so this is a paper by my colleague and mentee who's now on faculty with us at Northwestern, Ravi Patel, also analyzing this PROMISE study. And so what we hypothesized is if we look at LV global longitudinal strain on the x-axis and LA reservoir strain on the y-axis, that there is a correlation, but it's not, it's a loose correlation. Of course, the LA and the LV, like I showed before, is connected by the mitral annulus. But there are patients who have a pretty robust and preserved LV longitudinal strain, but their LA reservoir strain is very reduced. And that's the LA myopathy. That's the LA myopathy phenotype. And so this is kind of interesting. If we look at their other echo data, they have the best LV diastolic and systolic function, but the worst hemodynamics, the highest PA systolic pressure and the lowest stroke volume. This is the LA myopathy phenotype. And we did a proteomics analysis and validated this. And look at this, the reviewers of this paper kept saying all you're looking at is AFib, but we show that AFib and this disproportionate LA myopathy do overlap with BNP and ACE2, but there's many proteins that are specific to LA myopathy and could be targeted in the future for pharmacologic approaches to improve LA function. And so what we've been studying currently while we await these pharmacological approaches is putting an iatrogenic atrial shunt into these patients to decompress the LA. So this comes from the Luton-Bachet syndrome. Luton-Bachet, over 100 years ago, described a congenital ASD in the setting of mitral stenosis. These patients do better. We can decompress the high LA pressure. The large reservoir of the right atrium and great veins can hold this volume. And can we do this for HFPEF? And early on, I've been working on this for over 12 years. David Sellemeyer in Australia was the first to kind of conceive of this and start one of the first companies, the first company actually, to do this. And in those early days, we dug up this paper, which I think is really sort of prescient. So this is masked LV restriction in elderly patients with ASDs. So what they did in this older patient is they balloon occluded the ASD. You can see the wedge pressure is a little elevated at rest, but look what happens when the ASD is occluded. And remember, big V waves most often is not severe MR. It's a stiff LA. And this is exactly what we see in our HFPEF patients with exercise. And so when you close the ASD, you have this sort of HFPEF phenotype, and if you open it, you can decompress. And so this is what led to the development of devices like this. This is the intra-atrial shunt device, and it's an 8mm shunt, dynamic decompression of the overloaded LA chamber. And you try to get just enough unloading, but not a very high QPQS. So the QPQS here is 1.2 to 1.3. And now there are at least 7 companies in this space. It's really quite remarkable how much is out there now. But they're all in clinical trials. We did the first sham-controlled trial. This was published in 2018. So this was reduced LAP-HF1. You can see that after 1 month, there was really no hemodynamic change in wedge pressure during exercise in the sham control. But in the shunt device, we did see with legs up, and with exercise, we did see a modest reduction in wedge pressure. But studies have shown that this few millimeter drop in wedge pressure is associated with better mortality and less heart failure hospitalization. So it could mean something. I just want to show you this example, dramatic example from an older woman, a patient of mine with severe coronary disease, HFPEF. You can see that these top in darker, this wedge pressure, huge V waves, huge at baseline and just goes up even with, so at baseline rest and then with exercise, a nice reduction at 1 month below here. At 1 month resting and 1 month with exertion, really dramatic benefit with the shunt device. And we've shown that, the shunt device remains open, unlike some other devices that are closed prematurely. This device seems to stay open and really works quite well. And we published this a few years ago in JAMA Cardiology that you do see a reduction in cumulative incidence of heart failure. Take this with a grain of salt. These were a very small trial of 44 patients. But at 3 years, it does seem to be durable. And we can see here that this is now statistically significant. The shunt device treated patients seem to have less heart failure than sham control. And we have the pivotal trial that you all participated in, and the enrollment is complete and results are pending. So one thing that's interesting about the shunt device, when we first started, I thought, if we're shunting left to right, we're going to increase blood flow to the pulmonary vasculature. And these are older HFPEF patients with stiff pulmonary vasculature. We're just going to worsen pulmonary hypertension. But in fact, that wasn't the case. So if you look at the upper left here, we pulled the data, and QP obviously goes up. The pulmonary oxygen content, of course, goes up as well as we shunt left to right. But the pulmonary artery compliance went up, stiffness went down. And in fact, the more the pulmonary artery compliance went up, the better the exercise duration improvement. And so how is this occurring? How is it improving pulmonary hemodynamics? Well, potential mechanisms include lowering the wedge pressure. That'll lower augmentation of the PA systolic pressure. Oxygen, of course, could be a pulmonary vasodilator. And by increasing flow to the pulmonary vasculature, we could improve pulmonary vascular recruitment. And so, speaking to how important it is for patient selection, precision medicine, precision therapeutics, this is kind of an ideal case. This is an example of two 66-year-old women with HFpEF, patients of mine, who should get the shunt device. I mean, the whole point of my talk today and where we're going in the field is precision medicine. And the way we design the trial of the reduced LAP is to kind of leverage this and look for a specific phenotype, this LA myopathy phenotype or isolated LA myopathy phenotype of HFpEF. And so I think it's clear to you all that the patient on the left is the ideal patient. The patient on the right has RV failure, right heart is enlarged, the RA is bigger than the LA, not a good patient. And so we have to remember patient selection is key. And sure enough, on their hemodynamics, the patient on the right had a nice gradient between LA and RA, preserved cardiac index, and the PVR wasn't elevated. On the right, this is not the kind of patient a shunt device will help. This is the kind of patient perhaps greater splanchnic nerve ablation would help by lowering those wedge pressures and improving venous capacitance. And so I come back to this initial description by Eric Topol, and I want to highlight one thing that this is back in 1985. We conclude that this unique subset of hypertensive patients has a clinical syndrome that warrants recognition and tailored management. And I hope I've shown you today that that's the future of HFpEF, recognizing these subphenotype and performing tailored management. So the take-home points, HFpEF is a heterogeneous systemic multi-organ reserve dysfunction syndrome. Resolving the HFpEF heterogeneity with improved classification of HFpEF may lead to improved outcomes in clinical trial results. Machine learning with deep phenotyping of echo and other omics technologies will hopefully lead to reclassification of HFpEF, but most importantly, will lead to new biological insights. And in the future, there's many novel targets that are being tested. I think focusing on the left atrium, the obesity, the gut, et cetera, I'm hoping will lead to new treatments for HFpEF. And with that, I'd like to thank you for your attention and happy to answer questions.
Well, thank you very much for that fascinating talk. I think Dr. Naga has a couple of questions for you. And then,
thank you for joining us this morning and this great talk. You've presented the pheno groups, so to speak, more or less as discrete groups. You've also shown a slide where you said there is some good degree of overlap between cardiac components and non-cardiac components. Within the cardiac features of these three phenogroups, it is not uncommon to see an atrial reservoir function and even contractile function abnormal, a strain that is reduced, a diastolic dysfunction by different indices. Do these sort of play a role, or how would you use this data to sort of say this particular patient belongs more to group 1 versus 2 versus 3?
Yeah, that's a great question. I think the first and foremost important thing for people to understand is that, machine learning is not the panacea. It's not the solution to everything. It's a starting point. So I'll give you an example. What data you put into the machine learning model will give you different groups, even different numbers of groups. And so the point is, we're never going to have a black and white situation where we have very discrete phenogroups. Even though I presented that way as an example, we're not going to have a situation where we have these very isolated phenogroups based on machine learning alone. The point is to start the biological insight. And in fact, when you look at, if you took under the hood of the machine learning model, it's not yes, no, group 1, group 2, it's a probability. Like this patient has the highest probability of being in group 1. In fact, we did a longitudinal study where we looked to see if the phenogroups change over time. I call that the mutability of the phenomapping. And what we found is that there are patients that go from group 1 to group 2 and group 2 to group 3 and back and forth, and they were on the periphery. Their probability was already kind of right there between two groups, and so they can go back and forth. So the point is that we need to do this exercise to then take the next step and find the biological insight. So, like for example, what this did is it solidified our knowledge that there are these HFpEF patients with a low BNP and obese phenotype. And so we're going down that route. Ultimately, in the future, I think there will be blood signatures, proteomics or metabolomics that will help us identify what phenogroup or what biological mechanism is going on. And that's really the key. I mean, think about cardiac amyloid. We now have, for ATTR, we have PYP scans, which are, they're not perfect, but they're highly sensitive and specific and can help us understand biologically what's going on. And so I think that's what's important. Further to your point, left atrial strain, diastolic indices, there's going to be a lot of overlap between these groups. So that was the whole reason why we used machine learning in the first place, because there wasn't one indice that we could just hang our hat on that's this phenogroup. And so this is still an evolving field, but one I want to make sure people understand is that, machine learning studies are the vogue today, but there's still a lot more that we need to do.
Thank you for a very clear answer. The audience have sort of collectively added a number of questions. I'll try to sort of pick those that have been asked most frequently. One of them is the idea that patients who have HFpEF who do not have clear hypertrophy, nothing infiltrative or restrictive, or significant CAD. Do you see these patients? How do you deal with them? We understand your approach in reaching the diagnosis, but what are your thoughts about these patients? How frequently do they occur? And do you approach them in any different way?
No, I don't think I approach them any differently, but I want to make sure the audience knows that definitely you see these patients. So definitely there are patients with normal LV wall thickness and don't have hypertrophy or infiltration. And I would just use the same algorithm that I showed you during the talk today. There can be many reasons for this that occurs. And it can be as mundane as the fact that we index to body surface area, and many of these obese patients, once you index to BSA, don't have LV wall thickness increased, even though it actually is if we index to height. Or it could be that they really don't have LV hypertrophy. Not everyone has LV hypertrophy, and that doesn't mean that that's not the HFpEF syndrome. But it does make me think about the fact that maybe this is an LA myopathy going on, a primary LA myopathy, and really the left atrium is the problem. Or it's this obese HFpEF phenotype. And really the myocardium is pretty healthy, but it's all this adipose tissue encasing the heart that's really causing the problem. And so, I hope that the lack of LV hypertrophy shouldn't detract, and we should use the same tools we have and think about these other etiologies.
Thank you.
So some of the other questions are, can any of the proteins and metabolites be tracked to know if they're predominantly induced by a particular cardiac cavity or a particular group of cells? Have you done any tissue analysis?
So there's a couple ways to do that. There are, I think probably the coolest thing that's been done is looking at the gradient between, the sort of the transmyocardial gradient, looking at arterial versus coronary sinus versus venous. And there was a nice study published in Science about this, looking at, in patients undergoing AFib ablation, where they're off, or EP studies where they're often in the coronary sinus, and looking at the transmyocardial gradient. Now, of course, that's not too helpful because we're not going to be putting coronary sinus catheters in everyone, but we can get a sense of the biology in that way. There are times where we look at something in the myocardium using myocardial biopsy, and we try to correlate with tissue. People have done that with finding that certain proteins like SCN5A in the myocardium correlates with the amount in the white blood cells. So you can do something like that. There's sort of circulating vesicles that come off of tissues. I think people are doing a lot with that as well. But often it's hard, and that is part of the problem, that the tissue, myocardial tissue, and even other organs, and what actually gets excreted in the blood is problematic. I mean, I showed you the proteomic analysis and showing inflammation is so important. Well, guess what? Inflammation is what we can very much study in the blood quite well. Same thing with endothelial markers, because that's what's getting exposed to the bloodstream. So I think in the future, there needs to be much more study with tissue. We're doing a lot in the realm of getting old autopsy specimen, paraffin embedded specimens, and basically bringing them to life. Basically archaeologists looking at these old samples. Now we can do a lot of tissue analyses like RNA-seq in these old samples that we weren't able to do before. So it's a really exciting time to learn about the biology of syndromes like HFpEF.
And Dr. Zogby also thanks you for an amazing and comprehensive discussion of HFpEF. And he has a question: if the tissue Doppler is diastolic.
I think his question was cut off, so it's a bit incomplete. Hard to sort of tell what he was thinking of, but I guess one can ask, are there sort of a group of variables that you mentioned, obviously relying on more than just tissue Doppler, velocity signals, particularly diastolic signals, to diagnose the sick myocardium. Once you diagnose the sick myocardium, or one thinks that I've said this person has a sick myocardium, their outcomes are worse than others who do not have a sick myocardium. Do you tend to use more of the treatments of for example, the neprilysin inhibitors and the beta blockers and so on? Why is it important for you to go after the sick myocardium, if you would?
Yeah, the sick myocardium does two things. One, like I showed you some examples, helps us with etiology. And so that's really important in saying, okay, if this is a sick myocardium, is it infiltrative? Is it hypertrophic cardiomyopathy? Is it coronary disease? What is going on that's causing the myocardium to be sick? Oftentimes it's just the comorbidities and stuff. But there we can look for systolic dysfunction. Either the EF is on the lower end of the spectrum or the strain is very abnormal. And I do think that those patients are the ones most likely to improve with neurohormonal blockade. I think beta blockers are tough. The observational studies are mixed. I think that vasodilating beta blockers are sometimes helpful, but I always look for chronotropic incompetence because that can be a problem. But I think that, the other thing that's really important, and, we preach about this all the time and nobody ever really does it, is we look at all of our tissue velocities, our strain, we look at everything at rest. And this is a disease of exertion. And I'll say it here, you've heard this many times before, but we would never think of diagnosing ischemia at rest. I mean, we really want to diagnose it with exertion or some kind of stress. And we really need to do that. And I think you all are probably doing this as well, but we use a lot of exercise echo, bike echo with strain. And it's really fascinating. So we couple the Doppler, tissue Doppler strain to look at the whole picture of what's going on. Where is the heart, if it is the heart, falling apart during exercise? Even low-level exercise, you can get really nice signals. Is it the RV? Is the RV sort of dilating and the LV kind of getting smaller and smaller and more hyperdynamic? The blood may be, trapped up in the pulmonary vasculature. Is the LA completely falling apart? Is the LV falling apart, et cetera? That's really helpful. In fact, what we do with CardioMEMS patients is we put them on the bike echo table and we hold the CardioMEMS wand, and we can basically do an invasive hemodynamic stress test with echo, and we have a cardiopulmonary exercise machine there too. So I think that, we need to be thinking about how to incorporate exercise more and look at how the exercise changes. Even low levels of exercise change. What we're seeing on echo, I think, can be very helpful.
And another good question here which has come up is, within these phenogroups, are there stages of disease? How would you, can you use biomarkers to stage the disease in these phenogroups?
Yeah, one of our earliest questions are these phenogroups just stages of disease? Is phenogroup 1, then go to phenogroup 2, to phenogroup 3? That's kind of why we did that mutability study. And we didn't really see that. I mean, we saw a few patients go, like I said, from back and forth between the groups, but it was more that their initial probability was kind of on the fence. You don't really see much movement, but some of this probably is, of course, because we've seen patients with HFPEF who get worse and worse and worse and develop cardiorenal syndrome and RV failure. I think that, again, the phenogrouping was really to try to find biological mechanisms. But for sure, there are, within the phenogroups, there's, biomarkers and other markers of increased risk, and then across the phenogroups. I personally don't find like risk markers very helpful in my clinical practice. Of course, beyond what we have today. So I know like a BNP in the thousands, I know bad risk. Bad renal function, they're high risk. But how does that really help me when I don't have treatments, that are, if I had tons of treatments, maybe if I could get them all to transplant or something. So I'm less, intrigued by new risk markers and stuff like that. I want to know about what is going to tell me about the treatment. And that's where I think the field is going to be most benefited from. No doubt that, risk papers will still be published, and it is important, and I've published many of them. But I think we need more than that.
Well, thank you very much, Dr. Shah. I think we are now at 9 o'clock, so it was wonderful having you here, and fascinating talk. Thank you very much again.
We look forward to hosting you with us
in Houston. Yeah,
soon.
Hopefully,
once this is possible. Thank you.
Thank you, and thank you to the audience. Take care.
Bye.
Bye.